Greenway has bachelor's degrees in psychology and speech and hearing sciences, and his doctorate in audiology from Pacific University. He's an associate professor with the School of Audiology and has 2 years of private practice experience as a clinical audiologist. His professional interests include direct-to-consumer hearing solutions, tinnitus management, and expanding access to hearing health information. And outside of work, Dr. Greenway serves as the president of the Oregon Academy of Audiology and is a member of the Academy of Doctors of Audiology's Advocacy Steering Committee. So please join me in giving a warm Rotary welcome to Dr. Brian Greenway.
Thank you so much for having me. And a big thank you to Lucas and Janet and everyone else who put this together. I am the president of our State Audiology Association, so I understand how much work goes into making groups like this and events like this happen. So thank you to all of you. So as Lucas said, I am a professor over at Pacific. Our audiology program and our clinic are located on the Hillsborough campus. Not quite as beautiful as out here, but that is where we house all of our health professions, schools, and clinics, and that lets us do a lot of cool things in terms of interprofessional practice, research, and community building. So originally, one of my colleagues, Dr. Annie Hogan, was supposed to come out and talk. She unfortunately had to go back to the Midwest to take care of some family stuff, so I'm stepping in her place. Dr. Hogan is the director of Pacific's Interprofessional Diabetes Clinic. So she was going to focus a lot more on hearing loss and diabetes. I am still going to talk a little bit about that, but I don't have as much depth as she does on that subject. So I'm also going to talk about how audiology and hearing and balance health relate to some other medical conditions, or what we call comorbidities. So I'm going to give a quick review of hearing, listening, and balance, which are what we do as audiologists. We will talk about some of those comorbidities. I will introduce you all to how Pacific, through its school and clinics, help our patients and our communities who are working with those issues and those comorbidities. And I want to leave any time for questions at the end. So, quick poll. Who knows what audiologists do? Okay, got a few hands. I have been places where I get less hands than that, so that's great. So, audiologists are clinical doctorates, so very similar to physical therapists, pharmacists, optometrists, those kinds of professions. We're not MDs, but we do what we do in a very specific part of healthcare. We are basically interested in everything to do with the ear and hearing and balance. Remembering why balance, I'll talk about that in a few minutes. So when we look at hearing, it's a pretty complicated system. So when a sound wave enters your ear, it is going through your ear canal, it is going through the eardrum and all the little bones and muscles of the middle ear. It goes into the inner ear, what we call the cochlea, and that's where that sound wave is transmitted and transferred from sound into a neural signal, which travels up the 8th nerve, through a bunch of parts of the brain stem, and finally into the auditory center of the brain. So, hearing that, you can probably imagine there's a lot of things that can go wrong, and that's where audiology steps in. So, when you think audiologists, we are not surgeons, that's ENTs, the ear, nose, and throat doctors, and we do not prescribe medication. So, if there is a pharmaceutical or a surgical correction for something, oftentimes we'll identify what it is and then hand off to the surgeon or to another physician to treat that. Short of those things, we do pretty much everything else in terms of ears and hearing. So what most people think of when they think of audiology is hearing loss, and that is generally our bread and butter for most of our profession. When we talk about hearing loss, there's three main types that we talk about. So there is what we call conductive hearing loss, which is when something is blocking those sound waves from getting into that inner ear. And that can be a big blob of wax in the ear, it can be a hole in the eardrum, it can be an ear infection. Lots of kids get those, and we can work with those patients, testing and figuring out treatment plans. Beyond the eardrum and the middle ear space, when we get into that inner ear and the nerve behind it, if there's something wrong there, we call that sensory neural hearing loss. And that has to do with the sensory system, so the cochlea that takes those sound waves and transfers them into neural signals, and then the nerve itself. That is where, especially for adults, the vast majority, about 90% of hearing loss cases exist. So from things like noise exposure, aging, toxins either from the environment or even some medications that people take, those are all common causes of hearing loss. When a hearing loss is sensory neural, when it involves that inner ear or the nerve behind it, the vast majority of times those are permanent hearing losses. So we're moving from corrective interventions, we're not trying to fix it yet. There's some very, very promising research coming out, probably in the next 10 or so years. We'll have ways of reversing some of that damage. But for the time being, we are specializing in those areas in things like hearing aids for amplification, in rehabilitation and therapies to help people overcome the listening difficulties and the lifestyle impacts that go along with that hearing loss. And for some unfortunate, unlucky people, they can have both. So you can have something causing damage to that inner ear or that nerve behind it, and you can also have something blocking the ear. One of what I think is the coolest areas of audiology, which has grown more in the last decade or so, is beyond what we traditionally call hearing loss, we're also just focusing more on listening difficulties now. So we like to talk about that in terms of hearing is, does your brain realize that there's a signal, that something is coming through? Listening is the more complex system of being able to understand what that is. So if a sentence comes through, you can hear it, but do you understand what's being said? And we're coming up with a lot more tests and a lot more interventions now to help people who don't necessarily have hearing problems. Maybe their hearing test looks normal, but will still tell you in a crowded room, I'm lost in the conversation. Or with louder speech or softer speech, even though those hearing results are normal, I still just can't follow a conversation. So we are doing more and more work, especially with kids, which is great, but even with adults now, who are having those, what we call a normal audiogram, the hearing test looks normal, but they are reporting difficulties, and so we're treating those difficulties. We really try to drill it into our students that we do not treat conditions, we treat people. And if someone says that they have problems, then they have a problem, regardless of what our test results say. So balance. This is Dr. Hogan's baby. When we look at the ears, the back half of the inner ear is actually not having to do anything with hearing. It is all about balance and knowing where you are in space and how you're moving and not moving and everything like that. This is very, very important. It's something you never notice when it's working correctly, but when it's not working right, it is devastating and catastrophic to people. If you've ever had vertigos, the spins, those things are because of the inner ear. And the balance system as a whole works on, we used to call a three-legged stool, now call a four-legged stool. And all of these systems work together. So we've got the ear telling you where you are in space, if you're moving or not, if you're tilting or not. You have the eyes also telling you where you are, how things are in relative or in relation to you. We have the proprioceptive, or basically just the muscles and the nerves of the body. So I know that I'm standing here in front of you because my feet are telling me I'm standing here. My eyes are telling me I'm in front of you. My ears telling me I'm not moving. And the last stool is the brain takes all of that, puts it all together, and because of that, I'm able to stand here, know where I am, and not fall over while I'm talking to you. If any of those systems go wrong, the whole system as a whole kind of breaks down. So as audiologists, our point in this is generally in the vestibular, what we call the vestibular, so that inner ear system. And we do a lot of work as well with how that system connects and interacts with the eyes. So a lot of the way that we test if that inner ear is working right is by watching eye movements in response to different stimuli. So that is the 10,000-foot view of audiology and what we do. And one of the coolest things about audiology, while we love ears and we're happy to work on those specifically, we have, especially in the last 10 or 20 years, found a lot of kind of whole body health or whole person wellness things that go along with good hearing. And so we are transitioning from just being in our isolated little pocket on the sides of the head into looking at the person as a whole individual and realizing that what we do interacts with other issues that people have, and that other things that people have going on can also affect their hearing and their ears. So today I want to give you a brief overview of kind of 4 areas, and that's audiology or hearing health and mental health, cognition, which is a big buzzword area right now, ototoxic medications, and diabetes, which is what Dr. Hogan was going to originally talk about. So mental health and audiology is something near and dear to my heart. My first bachelor's degree was actually in psychology. I still love the mental health field. I came to audiology, but there's a lot of crossover. It turns out research backs that up. There is a lot of connection between hearing health as well as balance health and mental health. Some quick statistics on that. Hearing loss through research is very strongly correlated with increased depression in everybody, but especially in older adults. Part of what that comes down to, a large part of it, is social isolation. So if you're not able to hear, if you're not able to come to an event like this and hear well and have conversations, then what you're going to do is stay at home and not have conversations. And the more that happens, as we are all very aware from especially the past few years where we've been more isolated and more inside, it doesn't feel good to be away from people. So we see a lot of issues with hearing loss causing people to withdraw more, not do the things that they love, not see the people that they want to see and talk to. Anyone who knows someone with hearing loss will tell you it is very frustrating trying to talk to those people. So even if the desire is there to have those interpersonal relationships, a lot of times it kind of just naturally friends pull away from friends, families don't talk to each other as much, because the quality of that communication is just not as good. So the good news is there have been studies, especially recently, that have shown that when we treat the hearing loss, so for most people that means when we get the hearing aids appropriately fit for them, that very quickly improves mental health. As quickly as 3 months after fitting hearing aids, we are seeing improved scores on scales of mental health, depression, anxiety, overall well-being. So that kind of goes to show that we are really, again, we're practicing on the ears and the hearing system, but we have really strong connections to these other areas. And when you look at the healthcare system as a whole and what everything costs, a set of hearing aids is generally a less expensive solution for this than some of the other interventions that may be directly through mental health. Those are also very valuable, but we can play a role in that as well. Here is the big one. I imagine most people, if you follow the news in any way, have probably seen some kind of headline about dementia and hearing loss. And there is a good reason that that's happening. For a long time, audiologists and other people involved in hearing health, we have known that this connection exists. Anyone could have told you more hearing loss leads to a greater risk of dementia. Unfortunately, we didn't have that really good research to back that up. So ethically, that was not something that we could really talk about with patients or act on. In the last few years, and I mean, I graduated in 2019, and this has been since I was in school, we do, thanks to a lot of brilliant researchers, especially Frank Lynn out in Johns Hopkins in Maryland, we do have that science now. And all of that culminated in 2020 with a Lancet report. The Lancet is kind of the top tier of bringing research together and making statements about it. In 2020, the Lancet group said that hearing loss was one of 12 modifiable risk factors for dementia and other cognitive decline. And not only was it one of those 12, it is the largest proportion in terms of, if we look at someone with dementia, it is the largest modifiable factor that we can say that is why that particular person has dementia. Now, the caveat on that, the 8.2% you see there, that is the percentage of dementia cases that can be, at least in part, attributed to hearing loss. So, we are, where I tell my students and my colleagues to pump the brakes a little, is that even though we have this amazing research now, and we know that we are part of the solution for some people, hearing aids and hearing health in general, as much as we want to be, we are not a silver bullet for cognition for Alzheimer's or dementia. There are people out there for whom getting hearing aids are going to slow that progression or are going to hold off that dementia, but it's not going to be everyone, and it's not going to be the sole thing related that's causing improvement or delay of dementia symptoms. So we're walking a very fine line now where we can start talking about this with patients as something to have in their mind, but I always tell my students and everyone to practice ethically in audiology. We can't be using this as a scare tactic. So I never tell my patients, you need to get hearing aids because otherwise that dementia is going to come on. But if patients bring it up, then that is something that we will have a candid discussion about. The other part of it is, even though we now have the science that says hearing loss and dementia are very strongly linked, we don't quite have the science that really shows us that fitting a patient with hearing aids can greatly improve it. There are a lot of individual research studies that are showing that. Again, we're in that place where as a profession, we kind of know that this is the case, but we're probably still a few years off from being able to say with that really tier 1 research knowledge base that is the connection there. That fitting some patients with hearing loss will improve their dementia, will stave off the dementia, those kinds of conclusions. So we are definitely in a place where we know a lot more about that connection. That connection definitely exists. Odds are treating hearing loss is helping with that. But again, take it with a grain of salt as you read those articles in the news. So ototoxic medications. This basically means chemicals, specifically in drugs that we take, prescription medications that are prescribed to people, or environmental toxins. Some of those things will affect the ears. So they can make hearing worse, they can make balance worse, they can cause tinnitus or ringing in the ears. This is something that is near and dear to me right now. My mother for the past year has been going through chemo and radiation and other therapies for breast cancer. She's doing very well. But it was very enlightening from my position as an audiologist, seeing her interactions from the patient side of things. Hearing loss, vestibular balance issues were never discussed with her by her oncologist, by her primary care, by anyone involved in that. And that's unfortunately kind of the status quo that we're seeing. We know that obviously chemotherapy is, most people would agree, more important than hearing. So people are going to still use chemotherapy, they're still going to use strong antibiotics if those things are needed to save their life. And we don't want people not to do that. Where audiology comes in is we can test the hearing before, during, and after the use of these drugs. So again, the common ones are chemotherapy, very strong antibiotics. Aspirin is up here. That is a very, very, very high dose of aspirin that almost no one is on. So don't go home and throw out all your Tylenol. That's not something you should be worried about. But where we come in is we're able to track damage, and we give that information to the oncologists, to the doctors, and they can use that and decide if, so for example, in my mom's case, they were able to reduce one of the drug's dosages down a little bit, so it's still effective, but wasn't having the same effect on the ears as the original dosage had. So we are really interacting in doing that. Ideally, we want to see those patients either right before or right after each of their treatments, so we can get that baseline and then track the progress as it goes along. The other things that we do here are, if we know that there is going to be hearing loss, balance issues, or tinnitus, we can start that treatment early. So we can get people in hearing aids, especially because they are going through ongoing medical appointments and issues. We want them to be able to hear well for that period of time. Afterwards and during, especially with chemotherapy, we know that the dangers of chemotherapy can last for about 1.5 years after that treatment ends. And the biggest thing that we're concerned with that is not only is there direct damage from these drugs, there can be an increased susceptibility to noise damage. So if you've had chemotherapy for about 1.5 years afterwards, if you use the chainsaw, if you go to a rock concert, your ears are more likely to be damaged from that. So we can counsel patients on hearing protection, what to avoid, we can get them custom earplugs, and make sure that people are protecting the hearing that they have to have the best outcomes following the treatment. One other very cool thing that has just recently been approved by the FDA, and OHSU here in Portland had a big role in getting this passed, is there is a new drug that is currently just approved for children, but they take it before they get cisplatin, which is a common chemotherapy drug, and it has been shown to reduce the amount of damage done by that drug during chemotherapy treatment. So again, another area where we are seeing a lot of growth, a lot of potential, and a lot of forward movement. So diabetes, I don't need to tell you, it's very common and it's becoming more and more common. So in a nutshell, diabetes is the body is not able to regulate blood sugar the way it's supposed to. So the sugars in the blood are too high, too low, they can ebb and flow. And this can be acquired, it can be congenital, and it can affect a lot of different things. And the main reason we see that effect across the body is that when this happens, we see that it affects the nerves, so it causes nerve damage, and it also causes damage to the very small blood vessels that supply oxygen to all parts of the body, including, at the head, the ear. So all the red lines in here are all of the tiny blood vessels and arteries that supply the ear. Like with the rest of your body, if the ear is not getting oxygen, it's going to start dying, either quickly or slowly. And what we see is, as that happens, the little hair cells in your inner ear that detect sound and turn it into neural signals, those start to die off. And the result of that is that people with diabetes, and the more severe the diabetes is, the longer a person has had it, the less well controlled it is, the bigger this impact. But people with diabetes on the whole are about twice as likely to have hearing loss than someone equivalent who doesn't have diabetes. People with even pre-diabetes are about a 30% higher likelihood of it. And we're also seeing, for a lot of different reasons, both in the ear and, like I said, things like peripheral neuropathy, so not being able to feel your feet as well, that also leads to higher risks of falls in these patients. So there's our four-legged stool again, and again, diabetes can affect all of these legs, so falls are much more likely. So what do? We are monitoring our patients. We tend to see our diabetes patients more often than our other patients because changes can occur fairly quickly. We are working with their medical team on the whole to use that information to improve care. The other thing is, you never know what that thing is going to be that's going to get someone to change their behaviors. And I see this with our patients who smoke as well. If you've got someone with diabetes who is not doing what they need to control it and to manage it well, there's going to be something that's going to encourage them to. And for some people, if you have someone who's diabetes who also loves music or other audio stimuli, letting them know, hey, if you can't get your diabetes under control, music's not going to sound good anymore. I'm going to have to get you hearing aids. This is not going to go as well. Maybe that's the thing that's going to kick them into feeling like they want to do something about it. So how else do we help out? Again, if there's damage to the inner ear, we can fit hearing aids. We can give auditory training to help people understand better, either with or without hearing aids. And especially with balance, we can be part of the team that is diagnosing and treating balance disorders. So there's a lot of balance therapies, exercises that people can do at home or in a clinic to help them keep from falling. Because falling is one of the biggest issues, especially in older adults, that we're trying to avoid, and audiology plays a big role in that. Okay, so the last part here, how is Pacific helping with all this? Basically, we do it in 3 ways. We have our Pacific School of Audiology, we have our Pacific Ear Clinics, and then we have our Interprofessional Diabetes Clinic. So the School of Audiology, there's some pictures of past cohorts and events that we've put on. It was founded in 2012. We're a 3-year accelerated program. It's normally 4-year. And we have put out, as of now, over 200 audiologists into the country. We are one of, if not the largest cohort in the country. So a lot of audiology programs are 10 people or less. We routinely put out 24 to 27 graduates a year, which is important because we are in a place right now in time where we have more and more people turning 65 every day, and we're also identifying these other things, some of which I've talked about, that are bringing even younger people into our clinic. So we are really trying to keep the amount of professionals at a level that is enough to support all the patients out there. Our students are in the classroom for most of their first year and part of their second year, and then complete through their second and third years 4 off-campus clinical rotations where they're working with practicing audiologists and basically gaining the skills so the day that they graduate, they can step into a clinic and start practicing on their own. Just some more pictures. So this is our simulation lab and one of our classrooms on campus that let our students get really good hands-on experience before they even touch a patient. And then right next to our school campus, through a doorway, is our Pacific Ear Clinic. So we, as of last summer, we now have 2 clinic locations, one in Hillsborough, a hospital right across from the Pacific campus, and then one on the Portland State University campus in downtown Portland. And we are we're getting to be full service clinics. So we do hearing, we do ototoxic monitoring, we do balance treatment and testing. We are looking at adding cochlear implant services as well as auditory processing services. So that's those people who have normal audiograms but have something in the brain or in the higher kind of level of hearing where they're just not listening as well as they could be. This is our Hillsborough clinic. We've got 2 hearing booths. We see all ages, so from babies who don't pass their newborn hearing screenings all the way up through older patients and everything in between. This is our brand new Portland State Clinic. They had the booth and everything, so we just got to move in and start seeing patients, which was great. And then the last thing I want to talk about, and this is, again, Dr. Hogan, who is supposed to be here today, is the director of our Interprofessional Diabetes Clinic. This is a very cool program that we have at Pacific for several reasons. From my view as a professor, or my selfish reason for loving this, is that we get to bring all of these students together. You'll have a student from optometry, dental hygiene, occupational therapy, pharmacy, social work, and audiology team up. They all get one patient. They follow around for the day, so they get to see what the other students do as part of their care, and then they get to do their corner of taking care of that patient. For us, it's testing the hearing of the patient, and then doing another test to check for early signs of damage in the inner ear. And at the end, they put together a presentation for everyone else based on that patient about how they would want to move forward with them, what care that patient needs, and all of that. We generally see we're a pro bono clinic, so we see low income and uninsured patients who can't otherwise afford care. And we go, because we have all of those, we're looking at medications, we're looking at lifestyle, we're even looking at doing things like helping them get healthy food when they're out of our clinic, helping them get assistive devices. Are they able to track their glucose? Do they have socks that are going to help with the effects of diabetes on their legs and on the calves? Basically all those things that go into living a healthy, happy life, even though they have diabetes. So in summary, diabetes, as with everything, the ear is really, really intricately affected, both directly and indirectly, in that we need to be able to hear well to make it to medical appointments, to keep up with medications, to talk to our families, to remain employed, all of those things that are important for people with diabetes that are beyond just that diabetes itself. And that is all I have for you today. So thank you so much for the invitation and for listening. If we have time, I'm happy to answer questions. Otherwise, I'm also happy to stay after if we don't have time. So we'll look to
your comment about listening, I feel like coming out of the pandemic and being in social settings, I've had trouble picking out conversations in ways, and I wondered if am I just getting old, or is this not being used to? And so I'm curious about what techniques you use to treat that, or just more information.
That's a great question. So I think a lot of people, and keep waiting for research to come out on this, I think a lot of people are experiencing that. And I think what that basically comes down to for the average person is that